Thanks so much, and I'm hoping then you can hear me. And on the subject of trauma-related dissociation, I hope it isn't too much of a sense of dissociation, my being here in London, Ontario now. I wish I was there in presence physically. We'll talk about the distinction between mind and body. I guess I'm not there in body, but I am there in mind and spirit. So I'll just begin on this topic then of trauma-related dissociation, and I'm sorry that I haven't been able to hear the first parts of the day. Not sure to what extent the idea of dissociative experiences as they relate to trauma has been discussed already. But this will be very much the focus of this presentation, and we'll talk about both assessment and treatment, and really a conceptual framework that we put forward, my colleague and I, Dr. Lanius and I, and really is the focus of the book that you mentioned in the introduction. So we might just ask the question first, what is dissociation? And in the literature, really, there's at least three ways of defining this construct. One is as a compartmentalization of psychological functions. And this really is the definition that's accepted or put forth in the DSM. And we have, for the fifth version, a definition given as a disruption and or discontinuity in the normal integration of consciousness, memory, identity, emotion, perception, body representation, motor control, and behavior. And I thought David Spiegel put this very simply and elegantly as saying, in essence, what dissociation is that aspects of psychobiological function that should be associated, coordinated, and or linked simply are not. So as we normally might have memories, we would have a sense of an identity forming, for example, through those memories. There might be emotions associated with the memory. Of course, there are perceptions. There could be a sense of the body in that event and of controlling the body through movement and behavior. But for example, with dissociation, we could have a memory without a sense of identity associated with it, without a sense of any emotion associated with it. Perceptions might be altered. The sense of body might not be present. The sense that one can move might not be present either. And so essentially we have these different psychological functions separated, dissociated. Another definition really emphasizes from the perspective of one particular diagnosis, dissociative disorder diagnosis, that is dissociative identity disorder, that there is a division in the individual's personality. And so if we think about the individual's personality as a dynamic biopsychosocial system as a whole, determining their mental and behavioral actions, we would think about that system being divided into several subsystems that in the normal individual, we might still have these subsystems, but there's, imagining the Venn diagram, much overlap between each subsystem. But instead, with the dissociative identity disorder, there's less overlap between each sense of self. And so the dissociative parts of the personality are quite separated from each other. And the concept that each would have a minimally rudimentary first-person perspective is part of this definition. And then so in experience, this division would manifest as different symptoms of dissociative disorders. And we can distinguish between positive symptoms and negative symptoms as we do in schizophrenia, for example. And we can also differentiate between psychoform or psychological symptoms and somatoform symptoms that focus more so on the body. We can also, though, differentiate a third definition of dissociation, and this one comes from Cardina and Carlson, and this is to recognize dissociative experiences as alterations in consciousness. And these might come in the form of a loss or of continuity in the subjective experience, which is associated with intrusions into awareness of various other symptoms. And this, again, would be called the positive forms of dissociation. It could also be an inability to access information or control certain functions, manifesting as gaps in awareness, memory, self-identification. And this would be then the negative forms of dissociation. And then broadly, there is often a sense of experiential disconnectedness that might include perceptual distortions as well, referring to the self and the outer world. And it's really rather the latter definition that we'll emphasize in this talk or this perspective. But we could also then think about, these are the different forms of dissociation, but what is the function of dissociation? And we do want to think that, of course, if this is a capacity of the person to dissociate, that it must have served some purpose. It must have evolved to serve some function. And so this idea then is brought forth with this slide, saying that a phylogenetically important aspect of the psychobiological response to threat and danger might involve different aspects that we now think would be correlated to dissociation. For example, an automatization of behavior. We don't want to think very carefully about what to do in a highly threatening situation. Rather, we have to act rapidly, and so to automatize the behavior would be important. For analgesia, for example, if we cannot escape a threat, and so we know must endure some degree of pain, the analgesic response might be adaptive then. And then the depersonalization, the sort of out-of-body experience, we're not so sure how that might itself be adaptive, but it might be the byproduct of some of these other kinds of functional outcomes that then is correlated. And so to survive the event, this notion of having this dissociative experience might actually be helpful and potentiate the ability to survive. However, this kind of an experience might become chronic in the aftermath of trauma, and then we have potentially a dissociative disorder. But again, the concept then would be to provide the psychological escape when the physical escape might not be possible. So then, measuring dissociation, we have different scales and such that we would use in psychology and psychiatry, and much literature is based on this dissociative experiences scale. And we want to emphasize then there's on the one hand a non-pathological form of dissociation. This is the everyday kinds of experiences that more or less we all have. For example, the highway hypnosis of driving, riding in a car, bus, subway, suddenly realizing you don't remember what's happened during all or part of the trip. Finding that you're listening to someone talk, but you sort of tuned them out and suddenly you realize you didn't really hear what they said. These things are everyday kinds of scenarios that we all experience more or less. However, there's some other forms as well, and still within this concept of non-pathological, we can think about absorption. We're watching a movie, a TV show, and we feel so absorbed in the story of what's being described, we're sort of less aware of what's going on around us. Or we similarly become so involved in a fantasy or a daydream that sort of time passes by, a good deal of it. It feels as if in this imagination the things are really happening. But on the other side, we have the pathological dissociation. And this is really heterogeneous concept, as we'll see from some of the examples from the dissociative experiences scale. Feeling as though you're standing next to yourself, watching yourself from outside of yourself, as if you're looking at another person, looking in a mirror and not recognizing yourself, feeling that other people, objects, the world around them are not real, like your body doesn't belong to you, or remembering a past event, for example, a traumatic event, so vividly that you feel as if you're reliving the event. These kinds of experiences are less frequent, essentially, lower base rate than the non-pathological forms. And they are in this category, then, of the pathological forms of dissociative experiences. And essentially, the more a person is endorsing, the more of these that a person is endorsing, it's more likely that they might be suffering from a more significant dissociative disorder. Well, we now have recognized in the DSM-5 as the dissociative subtype of PTSD. And so, of course, we know much about PTSD, and we won't review that. But here, now we recognize that certain persons with PTSD will experience dissociative experiences to a large extent, or frequently and with significant severity or intensity. And in particular, the dissociative subtype focuses in on two forms of dissociative experiences, the depersonalization and the derealization. And so these are defined here on this slide, and there's this much overlap here in the definition. The depersonalization, however, really focuses on the experience of the self, and it might be in the body or in the mind or in the emotions, but there's this experiential detachment that we talked about as an alteration of consciousness that's experienced specifically in respect of the body or in terms of one's thoughts or feelings. We don't feel sort of that they're ours. We might not have a sense of ownership of the experience, and we sort of have this sense of detachment, feeling outside of the experience. And it might manifest as though a person's in a dream and such, but that really is rather the trademark of the next, the derealization, which is the disconnectedness from the outer world that is experienced. Experiencing the surroundings, the world around you, including other people, as if they're dreamlike, distant, distorted, effectively unreal. And so these disturbances can't be better accounted for by the physiological effects of substances or other medical conditions. So the dissociative subtype then is the presence of PTSD together with these additional problems, depersonalization or derealization, or of course both. And there's different ways to try and understand the relationship between dissociation and PTSD. On the one hand, some might accept PTSD as a dissociative experience. So the dissociation is the broader concept, and PTSD is just one example. But really, this is not the model that we're going to suggest today, and really hasn't fit so well with the research. There could conceptualize two different constructs, PTSD from dissociation, that are nevertheless correlated or comorbid. One disorder, we're more likely to have the other. And this is certainly true. At the same time, we could think about PTSD as sort of the causal agent. The problems with PTSD cause, for example, dissociation, as well as other symptoms or mental health problems, for example, substance abuse. And we might think about the dissociation or, for example, the substance abuse as coping strategies to deal with the problems of PTSD. This would be another viable consideration and way to conceptualize the correlation. But what we're going to emphasize today is that the concept of a PTSD presentation with dissociation is not equivalent to a PTSD presentation without dissociation. So essentially, the argument is that the presence of dissociation provides a sort of qualitative distinction or grouping the one group with versus the other. And so might there be some evidence for this kind of a conceptualization? And a good number of studies were conducted in the early 2010s. And we conducted one of these, so we'll just review it in terms of how we've come across this concept of potentially a subtype of PTSD defined by dissociation. And one statistical methodology really that's sort of led to this concept is the latent profile analysis, but also we'll discuss the confirmatory factor analysis as well. So we started out with a civilian sample, and if you're not familiar with these sort of statistics, this kind of graph might give you a little bit of a sense of what's going on. Let's say we have 16 people, the rows in this table, and they're asked 5 different questions, A through E. Well, we can think about the latent profile analysis as sorting people into groups, whereas the confirmatory factor analysis would be sorting the symptoms into groups. So here I've sort of put it together that there should be some kind of patterns that are pretty obvious for everyone in the room to identify. On the one hand, sorting people, we can basically see that there's at least these 2 groups. And sort of the group of the first 8 people they're, saying for H, let's imagine that stands for high and L stands for low. They're saying, I'm experiencing ABC at a high rate for the first 8, but the next 8 are saying ABC, no, they're experiencing those at a low rate. So this would group the 16 people into 2 groups. But then we would also potentially see subgroups. Within the first 8, they've said high the first 4 would say high to ABC and also high to D and E, whereas the next 4 only say high to ABC and low to DE. So now we end up with these different groupings, okay? And we have all the highs across the board, the highs, the lows across the board, and then the lows and highs. So this would be the latent profile analysis of sorting people into groups. And then the confirmatory factor analysis would sort the symptoms, the questions. They would say, hey, the statistic would identify that, hey, these questions about A, B, and C tend to go together. If I say hi to A, I'm going to also very likely say hi to B and C. But it sort of goes differently for the next 2 questions, D and E. If I say hi to A, B, C, doesn't mean I will say hi also to D, E. They're sort of different sets of questions, so we would group them that way. So we would end up with sort of 4 groups in this, with this table of data, if this was real data. But what we're going to find in the statistical outcome with PTSD and dissociation is the questions that we don't get 4 groups here in the study, we get 3. And we'll see what those 3 groups are. But we started with 134 participants. 121 were women, so very much a female sample. And about 3/4 of the sample had childhood maltreatment history as the major trauma that they experienced that brought about their PTSD. And as far as the results, we did the latent profile analysis, and we did identify the 3 groups. One group was essentially just associated with low PTSD severity together with low dissociation. And this was an overall about half of the participants. So we would put them in the overall just low group. Then the next half divided basically equally into those that had high PTSD together with low dissociation or high PTSD together with high dissociation. And the high PTSD, high dissociation group not only scored high on the questions around depersonalization and derealization, but they all scored broadly high on the DES, that is the Dissociative Experiences Scale, which, as we said, has a heterogeneous content asking about many different kinds of dissociative experiences. This group also had particularly high physical and sexual abuse histories when they were children, and it also was more likely to report comorbidity with depression and a specific phobia. As far as the confirmatory factor analysis, this was conducted back with DSM-4, and at the time, then there was really sort of a factor analysis model that would distinguish between 4 different factors of DSM-4 PTSD. You have the re-experiencing symptoms that you're all familiar with, the intrusive memories, daytime, for example, or nighttime in nightmares, the distress that can be experienced at the reminders of the trauma. There's the avoidance symptoms, cognitive and sort of behavioral forms of. And then we have the emotional numbing symptoms and then the hyperarousal. So this is the 4-factor model of PTSD. So we would ask the question, well, how does the dissociative experiences of depersonalization, derealization fit into this model? And it was found to be a 5th factor then. And we might conceptualize this 5th factor as sort of an entirely independent, unrelated to the other 4. But that was inconsistent. Rather, the confirmatory factor analysis would say that dissociation was correlated with the other kinds of experiences, which would then be more consistent with conceptualizing these dissociative experiences as part of the PTSD syndrome, at least in the persons that are experiencing these dissociative experiences, rather than, for example, the independent comorbid perspective that we considered as another conceptual model of the relationship. Also, as you might know, there's 5 different sort of presentations of the re-experiencing that sort of led on this factor, but we also found that we could subtract out the second symptom of re-experiencing and put it over here on the dissociation side. Essentially, the fit of the model was identical if you did that. And what is this question, the second one, about re-experiencing? This is having to do with flashbacks, the sense that the memory is happening in the here and now, potentially associated with perceptual alterations, that is akin almost to hallucination, seeing and hearing things that are reminiscent of the trauma as if it's happening in the here and now. And so this kind of result also leads one to consider that these flashbacks might be also sort of dissociative in nature. And indeed, we saw in the dissociative experiences scale, one of the questions, the last one that I described, was evidence of a flashback, reliving a memory as if it's happening in the here and now. More recently, we've done a similar study with the DSM-5, and we were the first to assess whether these experiences of depersonalization and derealization also form a subtype relative to the DSM-5 symptoms of PTSD. And this was in an online study using MTurk, where we started with 2,700 participants, 2,500 of whom, 9 out of 10 of whom, completed the PCL-5 and a questionnaire that we've developed, TRASC, standing for Trauma-Related Altered States of Consciousness. Of those 2,500, the majority also completed additional measures of dissociation and such. And of those, about 550 or so, about 1 out of 5, scored high enough on the PCL-5 that we would suspect they might meet criteria for PTSD. And we have various demographics. About 70% were women, mean age in sort of young middle age, mainly Caucasian, about 74% and such. Just to look at the clinical history, just in response to one question, 63% reported suffering from a diagnosed psychological problem, whether it was currently or sometime in the past, but not currently. And just to operationalize the experience of depersonalization and derealization, we described in the questionnaire these dissociative experiences as follows. Depersonalization really focused on the out-of-body experience of feeling detached, separated from your body, feeling like you're looking down on yourself from above or like you're outside observer of your body. And derealization was feeling like you weren't what you're experiencing is not real, a change in the way you perceive or experience the world or other people, so that things seem dreamlike, strange, or unreal. In doing the factor analysis, we identified these different factors for re-experiencing, in purple, in blue, emotional numbing and anhedonia, and then in red, dissociation. We also identified factors for negative cognitions and mood, avoidance, and the hyperarousal questions of hypervigilance and startle reactivity that identify Leonard Stim's factor, just defined by those two forms of hyperarousal. And if we look at this sort of pie chart in terms of the percentage of variance accounted for, when we look at the whole questionnaire of the PCL-5, the 20 questions of PTSD, plus the 2 questions of depersonalization and derealization, when we look at the whole variation across the sample, in 557 participants who all sort of scored high in this questionnaire, perhaps in probably might meet criteria for PTSD, we see a large variance accounted for by the dissociation factor. It's actually the third highest percentage of variance accounting for over 15% of the variance. And this is a very lot of numbers, and what to make of this will draw your attention to a few things. We did, as I said, identify this factor. Negative cognition in alterations in mood and such was one. We had re-experiencing, we had avoidance, we had the Sims hyperarousal. Here showing the anhedonia, emotional numbing factor, having to do with loss of interest, feeling distant, cut off from emotions, and inability to experience positive emotions, that is anhedonia. We also have a factor in purple, the hypervigilance and the startle reactivity that I mentioned, Leonard Sims hyperarousal factor. And then we have the dissociation factor. And indeed, it was very specifically about questions of depersonalization and derealization that sort of loaded on this factor. And then we can look at the relationship between the factors. And we can see that the dissociation factor was correlated with re-experiencing, to a lesser extent, emotional numbing, anhedonia. It was not correlated with avoidance, but it was correlated negatively with hyperarousal. Now, I'm just going to use this color coding in the next slide. So we're going to talk about, in green, this loss of interest, feeling distant, the inability to experience pleasure, love, and then in purple, the hypervigilance, the startle reactivity. So the next slide really does the sorting into groups. And so of the 557 participants, how do they sort of sort into groups using this latent profile analysis? And the first group, we have this sort of pattern in green. And along the bottom, we have the R1 versus up to 5. Those are the re-experiencing symptoms. We have the A1 and A2, the avoidance, the N, negative alterations in cognition and mood, of which N4, 5, 6, the later ones, 7, have to do with the questions about emotional numbing. And then we have the hyperarousal questions, in particular the middle ones asking about hypervigilance and startle reactivity. And then finally, the DR and DP stand for derealization and depersonalization. So this first group has this particular pattern, and we can't really tell much from the pattern until we compare it to another group. So this first group in green, we might compare it to the next group in purple. And then we start to see some different patterns. For one, we might just say, if we just took a mean across all of these different PTSD symptoms, just drew one line, we would actually end up with basically the two groups looking very similar, having an overall average that's not too different from each other. So we're going to call them moderate PTSD overall. But we can see differences in the pattern. And pretty clearly for the green group, they have this bump in the middle asking about the questions of emotional numbing and anhedonia and such. And so we see that they are higher than the purple group with the experience of emotional numbing. Whereas in the purple group, towards the end here, there's a little bump around the hypervigilance and the startle reactivity, so we might call this a hyperarousal group. But what's really important, at the very end, the DR and DP, we can see that both groups do not endorse derealization or depersonalization with any significant frequency. But the next group in red, then, we do see this lack of a dip at the end of the graph. So this group, overall, if we draw a line, and it almost is a line, sort of a flat line across, it's overall moderate PTSD symptom severity, but together with, yes, the presence of the derealization and the depersonalization. The next group has an overall high level of PTSD severity and also does not include that dip at the end for the derealization, depersonalization. So here we have a group that has high PTSD severity together with high dissociative experiences. And the critical group, though, is the very last one in blue here. This one has high PTSD symptom severity overall, but still has this dip. So it's not just the group, the highest group in red is an overall high PTSD symptom severity, period. It's rather that we also have this blue group. You can have high PTSD symptoms, but not endorse the dissociative experiences. That's shown by the blue. So that's a critical distinction and consistent with the notion of a subtype of PTSD. And if we look at the percentages, we can see that they more or less are pretty similar percentages. The moderate dissociative subtype in red for 10% is a little lower, suggesting that it's less likely that you're going to have only moderate PTSD symptoms with the dissociation. It's more likely that if you have the dissociation, you also have high PTSD symptom severity. So my close colleague then, Dr. Lanius, has done some research, and of course I've been working on this research with Dr. Lanius. We work closely together. And this model was put forth in the American Journal of Psychiatry in 2010 that we might conceptualize the dissociative subtype of PTSD, not just at the psychological or the phenomenological level in terms of the presence of these self-reports of depersonalization or derealization, but also that these reports would correlate with experiences in the body, that is in the autonomic nervous system that we can measure objectively in terms of hyperarousal as compared to hypoarousal, and then also in the brain. And in the brain, the model was familiar for on the PTSD side without dissociation that the medial prefrontal cortex, the rostral anterior cingulate cortex, might act to suppress an overactive threat perception system in the amygdala and also an overactive feeling of hyperarousal in the body, perhaps manifested as a biomarker in the insula. But on the dissociation side, instead, we have this strong medial prefrontal cortex response and strong rostral anterior cingulate cortex response that then shuts down the amygdala and insula. And this is borne out more or less in several studies conducted since 2010. So now what we're going to turn to, though, is a model that describes PTSD and dissociation in a more complex way than is described just by these two questions of depersonalization and derealization. And what we're going to talk about here then is our 4D model, which is essentially just to say we have four dimensions that we talk about to try and differentiate the PTSD presentation in a sense of normal waking consciousness, that is an absence of alterations in consciousness, as compared to the presentation associated with trauma-related altered states of consciousness, the short form or acronym TRASC we'll talk about. So if we go back to Bester van der Kolk's original book, and I understand that what was one of the Door Prizes, the more recent one, and a quote from this one, this early book, suggested that perhaps the conceptualization at the time, DSM-4 PTSD, was, in the author's view, inadequate to fully account for the problems experienced by persons with trauma. Despite efforts to capture the essence of people's response to trauma, the PTSD diagnosis in the author's opinion was not, doesn't even begin to describe the complexity of how people react to overwhelming experiences. And so in their view, focusing solely on PTSD, describe what victims suffer from doesn't do justice to the complexity of what actually ails them. And similarly, though, Robert Spitzer, Michael First, Jerome Wakefield, on sort of the beginnings of the working forward to DSM-5, did suggest that PTSD was in a need to save it from itself. Essentially, the argument was made that symptoms of PTSD should be evaluated in terms of their diagnostic specificity for differentiating PTSD from other mood and anxiety disorders. And the authors advocate that only symptoms related to exposure to a severe trauma should be retained. In their opinion, PTSD, the way it's defined in DSM-4, includes too many symptom descriptors that are general symptoms of negative affect, general responses to negative events, stressful events that may not meet the criteria for a traumatic event. And so really to distinguish the PTSD syndrome, it was argued that it would be important to find or define a syndrome that was more specific to the traumatic life event. And one conceptualization might come back from William James, who characteristically was interested to differentiate the normal waking conscious state from other potential forms of consciousness that might be experienced, that is, alterations in consciousness. And so we might, quoting James, say the normal waking consciousness is sort of a rational form, we might call. We might just think it's only one special type. It's essentially not the only one. while it's all about this normal waking consciousness, parted from it by the filmiest of screens, there lie potential forms of consciousness entirely different. We might go through life without suspecting their existence, but applying the requisite stimulus, at a touch, they're there in all their completeness, definite types of mentality, which probably somewhere have their field of application and adaptation, and in his opinion, no account of the universe in its totality can be final, which leaves these other forms of consciousness quite disregarded. And so I just want to draw attention to a few things about that. First we could say, parted from it by the filmiest of screens. So what we might say here is then that these kinds of altered states are not so readily seen from the perspective of normal waking consciousness. They're entirely different, it's implied. So it's sort of implying then that it's a qualitative difference, not just a quantitative one. But apply the requisite stimulus. And this might be, for example, taking a substance, for example, might alter consciousness, but potentially the requisite stimulus would be a traumatic event. Experiencing a traumatic event would then be sufficient to provoke an alteration of consciousness outside the normal waking consciousness. And then it's held that these alterations in consciousness should have some application, be adaptive in some way. And so what function is it serving? And as we said, might serve the function of providing psychological escape when physical escape is not possible. So dissociation does correlate with PTSD. Does dissociation relate to trauma exposure? Across meta-analyses, we would say yes. Does dissociation relate to trauma severity? Yes, in a meta-analysis it does. Does dissociation level relate to the presence of PTSD? Yes, it does. Does dissociation level relate to the severity of PTSD? Yes, it does. The key really is to say, though, that PTSD can occur in the absence of dissociation. If you look at these effect sizes and these correlations, the correlations are not 1, they're 0.36. The effect sizes are not, 20 or something silly as high as that, but rather they're more like 1 standard deviation. And so what we know then is we can develop PTSD in the absence of dissociation. But dissociation does often occur in the context of comorbidity with PTSD. So a proposal now accepted. Of course, we've seen this slide before, that now we have a dissociative PTSD subtype recognized, defined by the depersonalization and derealization. But we want to sort of move beyond just that conceptualization and into 4 different dimensions: the sense of time, the sense of thought, the sense of the body, and the sense of emotion. And in terms of positive symptoms of dissociation, we'll think about the alterations in time and thought. And in terms of negative symptoms of dissociation, we'll think about the alterations in the body and the emotion. And each of these 4 kinds or sort of ways, dimensions of understanding consciousness can present in a dissociative versus a non-dissociative presentation. This is really the hypothesis put forward by this 4D model. So I wonder if I can just pause just for a moment to hear from maybe someone in the crowd, just to confirm that people are still sort of with me, and if there's any questions at this point. Is there anyone there that could speak?
We're with you.
Excellent. Thanks. I apologize. Of course, I don't even have a video for you, and so I'm just talking to a computer here, and it's not dissociative in any way, but it's a sort of funny experience. I can't see you nodding or anything like that. Yes, you understand, and so thanks for the check-in there. So I will just then carry on, and I'll just look forward to maybe some questions and comments towards the end. But what we want to talk about now is then each of these 4 dimensions of consciousness in a little more detail. The consciousness of time, or temporality, what's that about? Well, of course, we can try and understand the flow of consciousness across time, and there's a few obvious factors here that we could observe in terms of our sense of time. For one, it should be continuously moving. We're not sort of stuck in time, but rather time is always moving, and it's always in one direction, unidirectionally forward. Then we also want to think about different moments in time as being sort of seamless in transition. We don't, from the past to the present to the future, we have this flow of time. We don't have these kind of discrete moments in time that are sort of broken up and with spots missing in between. And so this kind of flow across the past, present, and future leads to sort of a sense of now, a spacious present. And, of course, if we want to try and understand this from a brain basis, something as complex as our sense of time, it's going to prove surely just as complex in terms of the neurobiology. We do know something about this. We do know that dopamine pathways are important in the striatum. We do know the supplementary motor area, the premotor cortex, the dorsal anterior cingulate cortex, the primary somatosensory cortex, the parietal lobe, the cerebellum. These various complex systems are involved in providing our sense of time to us. Here, though, for a person with a dissociative subtype of PTSD and an excellent artist, provided much material for our text, begins to describe the sense of time that might be experienced by the person with a dissociative subtype of PTSD, this disorientation, this lack of a sense of the passage of time, and this sort of scattered, sort of confused sense about what is past, what is present, what is future, for example, and the disorganization. And so what we want to do here, though, then is differentiate the symptoms of PTSD into a dissociative versus a non-dissociative presentation. And if we can think about remembering, we can think about the self in the present, and we draw the sense of consciousness through this kind of glowing that I draw on the figure here for the sense of the self in the present. So the consciousness is in the present. We look back to the past, and this is intentional. It's a choice. We want to look back and remember. This is how we might conceptualize the remembering. And hopefully we can do this through the context, for example, of trauma-focused psychotherapy, that we bring forth this organized choice to look back and understand better, to better appreciate and such, and move forward from what's happened. So this would be remembering, but comparably we have reliving. And one aspect of this is then to note that in the present sense, there is a diminished sense of self in the present, typically in the dissociative case. So the person doesn't really feel like they're in the present much of the time. They have this experiential disconnectedness that we talked about. So if we don't have a strong footing in the present, but then we experience an external reminder of something from the past, we sort of bypass this diminished sense of self in the present, and we feel like now we might be actually in the past, not the present. And we're experiencing the past as if it is the present. This is the nature of the reliving experience, the dissociative flashback. And so what we have done here is just plotted on different slices, sagittal slices on the bottom of and transverse on the top, different areas of the brain that we know from research, as we already mentioned, are important to our sense of the time. And so often how this is done is, for example, different tapping experiments. So if you imagine you're listening to a metronome, and it's clicking every so often, and we're tapping sort of along, and we're trying to keep the beat. And through this, it's been found that we can keep the beat pretty well up to about a 3-second period of time. Beyond 3 seconds, if we're trying to sort of tap how long that those 2 clicks of the metronome were, we often make more errors. We can overestimate or underestimate. And so we're quite accurate up to about 3 seconds. And this is one basis, for example, to try and understand that in humans, this spacious present is actually about 3 seconds. That's sort of the period of time that we would consider now. And then beyond that, more than 3 seconds into the past, we would consider it the past. And more than 3 seconds into the future, we would consider it the future. So this spacious present kind of unfolds over a kind of a period of about 3 seconds. So these different areas of the brain are going to be involved, and what we're going to see is that many of these same kinds of areas of the brain are involved across different dimensions of consciousness that we'll discuss, not just the consciousness of time, but the other dimensions, thought, body, and emotion. But what we tend to see, for example, the basal ganglia plotted sort of in red, or the insula in this kind of greeny blue, and the parietal lobe is implicated in purple and such, the cerebellum. So, it's very complex, and a number of different areas of the brain are going to be involved. But referring to the insula on the previous slide in that sort of aqua color, this has been talked about a lot in the literature, especially Bud Craig's model. He looked at a number of different tasks. And so, for example, in the brain slides towards the right, we have error awareness. I just realized that I made a mistake. And then the insula comes up. The sense of attention to heat pain is there. I'm paying attention to something that's touching my skin that's hot. And also then the insula pops up. The moment of recognition, that's kind of interesting. Oh, yeah, I remember that. Oh, yeah, I know you. At that moment of the, oh, yeah, I recall, the insula seems to pop up. And so across a wide array of different tasks, the insula was involved. And he said, okay, well, what's the common denominator across these tasks? And he felt that the only feature that's common to all these different kinds of tasks is that they engage the awareness of the subject. So in his opinion, the cumulative evidence compels the hypothesis that the anterior insular cortex might play a role in engendering human awareness. And the sense of time then would be important. Elizabeth Osach, going back to 2001, and Elizabeth is now at our university, Western University in London, and then Jim Hopper, Dr. Lanius and I, and the bottom, we also looked at the experience of flashbacks, and we found that as a person was recalling a traumatic memory in the scanner, the more they started to experience a flashback when they were primed to recall the memory through listening a script that reminded them of what happened, the more they were experiencing the insula active, together with less response in the perigenual anterior cingulate cortex and less response in the inferior frontal cortex of the right hemisphere, which has been associated with a suppression, sort of a stop response, sort of ability to regulate emotion. We want to think about, though, another consciousness, another form of consciousness. And this is sort of the verbal stream of thought, the narrative consciousness. And we can think of this in terms of sort of a referential nature. What do our thoughts refer to? They refer to the relationship between a subject and an object, the person who is having the thoughts, and then what is the content, what are the thoughts about? And so the thoughts might be about the self, or it might be about something else, the world around us, other people and such. So internal versus external. And we can think about these narratives as sort of like a story. We can use this metaphor, that the kinds of thoughts we have a subject, a perspective, usually in first person, but we'll talk about a deviation from that. They have their objects or their content, and then they also have a structure, a beginning, middle, and end. Now, what kinds of thoughts come up for persons with PTSD? Well, we have different questionnaires for that. We have the post-traumatic cognitions inventory. And these are examples, items from that inventory. Of course, people with PTSD are endorsing these kinds of experiences more often than people without PTSD. That they feel dead inside. They won't be able to feel normal emotions again. They've permanently changed for the worse. There's also just a list of single words that we developed in a study. People with PTSD are saying they might, these words describe themselves so that they feel that they are abandoned, they're defeated, they're a failure. They might feel discarded, demanaged. They might think they're inferior, alone, degraded, despicable, wretched, as a form of disappointment, or even disgusting or disgrace, unlovable, and sort of the really dark feelings and thoughts that we might have about ourselves are listed here.
And Dr. Frewen, we have about 5 minutes left for your talk, and then followed by 20 minutes of Q&A afterwards.
Thank you for that reminder. So we'll just try and wrap up, and maybe 5 minutes or just a little more, but I think we'll be very happy to have time for the questions and comments. I look forward to that. So how about beyond just a self-report? We could have an experimental approach. We could use tasks like this, putting up a picture of ourselves, actually a photograph. And while I put up this photograph, I rehearse I am if it's my photograph. Or it might be someone else's. I would say he is or she is. This is the visual, verbal, self-other referential processing task. That's a mouthful, but that's a task we developed to kind of try and study self-referential processing in the scanner through an experimental task. So if we said I am when I see my picture, and then I might have to read a word like worthless, that might say I am worthless. It sort of associates this, and it might make me sort of feel that way. I am a failure, and it goes on repeating various dark and negative words. How do I feel when I'm performing this task? Well, on the one side, it's just a survey. And in red, we have the PTSD group. In blue, we have the control group. For the self-negative words, we see the PTSD group is endorsing those negative words for the self more so than our controls. For the controls, they're endorsing the positive words more for themselves than are the PTSD group. For the others, though, how much do these words describe other people? For the PTSD group, comparing the two size or height of the red bars, we see that other people are described less by these words than they feel that those words describe themselves. But nevertheless, they do report that those words describe others more than do the control group. The control group would say rather that the positive words describe others, but not as much as they describe themselves. This is the self-positivity bias. How about, though, the next have to do with affect? How do I feel when I'm performing this task? Well, I feel very negative about myself when I'm presented with this experience of having to say I am a failure, for example. I surely don't feel positive about myself during that experience. How about, though, when I'm saying I am sort of a good person, I am lovable? For the PTSD group, they're actually experiencing a lot of negative affect when they're led to sort of associate the self with positive words. And so that is a distress that comes up. Perhaps they don't believe that about themselves truly, and so trying to perform the task creates negative affect. Not so much for the response to the other. And then in terms of the response to the positive affect, well, here, how good do I feel when I say I am lovable? The control group feels quite good about that. The PTSD group feels less good about that. Finally, in terms of the button pressing, we do look at response times, and generally we found that the response times are slower when it's my picture as opposed to when it's someone else's picture, as well as slower for the positive words than for the negative words. Especially when we're looking at our own picture, we might sort of slow down, we might sort of be looking more carefully. What kind of thoughts do the PTSD group actually come up with during this task? When it's a self-negative pairing, like I am worthless, they would say I relate to the negative side. I don't like this. It annoyed me. It was difficult. It was triggering, especially when you can't move, that is, in the scanner. How about when it's I am lovable? I questioned it. I didn't believe it. I believed them. it affirms how I feel. That would be a more adaptive, a resilient response. I don't know, just kind of there. It wasn't good or bad. It was just neutral, sort of a detachment. And we can look at the brain and we can see different areas of the brain involved in these different tasks, including, for example, the occipital cortex. The visual cortex was lighting up, especially for the PTSD group, when they were looking at the pictures of themselves, whether those pictures were positive or negative, paired with in terms of I am worthless or I am worthwhile. Whether it was either of those, when it was my picture, the visual cortex was lighting up especially for the PTSD group, implicating self-referential processing, both visually and verbally. But how about when it was the other person? We can also see then response in the medial prefrontal cortex, both the ventral and the middle, during the other referential processing, the response to the other, be it positive or negative. And we can also see response in the occipital cortex and in the medial parietal lobe in response to the other as well. And these are all regions of interest in the brain that are implicated in the sense of self and the response to others. So we might engage in different therapeutic activities to say that, I am scared, I am lonely, and how does this relate? Am I wanting to feel close to people? To go through these therapeutic tasks of trying to introduce some questions. Am I really fat, not smart? Do I really feel lost, confused? What specific memory is associated with these different forms of senses of self? And to try and evoke some positive senses of self. To feel that I might be a hard worker, a survivor, strong, associated with a self-defining memory. I want to feel whole again. I want to feel real and matter. From the first-person perspective, we might have these negative thoughts then. I hate myself. But to differentiate that, we might have thoughts, voice hearing in a second-person perspective. We might have voices inside our head feeling like I hate you. And this would implicate then a different alteration of consciousness associated with voice hearing. And this would be a dissociative experience, voice hearing as opposed to hearing just my own voice. It's experienced as if it's someone else's voice inside my head giving me the negative thoughts. We have talked about the out-of-body experience already, and this then is another alteration in consciousness from the sort of embodied perspective, the sense of being inside a body versus outside a body. And there's a lot of literature now, neuroscientific literature, to try and understand what parts of the brain are involved in this sense of feeling like I'm inside my own body. And part of the way to do that is to disturb it through different kinds of multisensory, perceptual and tactile experiments. And so normally, though, we feel like we're inside of the body, but there could be a sense of partial disembodiment. For example, like I feel like my hand is not my own, or full disembodiment where here is my physical location, but I feel sort of outside of that location in a different place, the out-of-body experience. And especially what's been implicated is the insula, but also in the right hemisphere, the temporal parietal junction in purple. If we stimulate this area of the brain, going back to Olaf Blanke's electrical stimulation study, we can actually induce out-of-body experience. And actually on the bottom of this graph on the right, we could see in the nearby, labeled here, superior temporal cortex, but many studies actually were in the right temporal parietal junction proper, the overlap that can be seen when a person actually experiences the dissociative out-of-body experience in response to, for example, a reminder of a trauma. And this area of the brain is not only involved in the sense of the bodily sense, but also in the theory of mind, as we saw there. And we can see that actually beginning to use RTMS, for example, to actually stimulate this area of the brain, we might actually have a way forward in terms of a treatment for depersonalization. The last thing I want to talk about is then emotions. We can think about alterations in emotions, and this would be the bread and butter, of course, of PTSD, that are negative emotions, not just fear and anxiety, but various emotions, guilt, shame, anger, and such. But what we want to really see, the concept of having emotions. We can think about the self as sort of separate a little bit from the emotions, thinking about the emotions as going through a bag, but having a break in that bag. We have different emotions: fear, guilt, anger, loss, and we feel these to a certain extent at different times. We might feel fear for a moment, but there's a break in the bag, and so we can let go of fear. Fear subsides. Similarly, for anger, we get angry, but then we become less angry. Guilt, loss, the different feelings sort of pass. Core affect, though, the sense of self is fully part of that emotional state. The sense of self is fully described by the emotional state. Are there any words that you can use to describe your emotional numbness? The numbness isn't a feeling, one of our patients said. Rather, it's just how they are. It describes the whole of the personality. And, of course, there's much areas of the brain involved in our sense of emotions and how we respond to emotions. But core affect, are there any words? As we said, it's not just a feeling, it's who you are. And we were the first to look at the neuroimaging of emotional numbing in the scanner and persons who were experiencing emotional numbing both during positive scenarios and negative scenarios, when they were sort of social scenarios, good things happening among other people, sort of feeling a part of it, or bad things happening in the context of relationships. This medial prefrontal cortex was less active the more the person was experiencing emotional numbing as they imagined the scenario. So then we've talked about 4 different experiences or senses of consciousness, the sense of time, thought, body, and emotion. And we want to then talk about them in a dissociative presentation versus a non-dissociative presentation. From the sense of self, in time, we can have the flashbacks, or we can just have the other forms of re-experiencing intrusive recall, reminder, distress. We can have our sense of thought in the form of dissociation, being voice hearing, or just the negative thoughts experienced in first-person perspective. We can have the sense of the body as sort of out-of-body, partially, or the full out-of-body experience, or we can actually have embodied forms of distress, the physiological hyperarousal that's more characteristic of the PTSD syndrome. And finally, in terms of emotions, we can think about the different emotions of fear, anxiety, anger, and such, guilt and shame as well. But we could also have this emotional numbing, and when marked, we would, in fact, say marked experience of emotional numbing, often present together with other forms of dissociation, such as the out-of-body experience, might qualify for a dissociative state. So the more in red is less frequent. The dissociative subtype is not the most people with PTSD do not have the dissociative subtype, but many do. We're talking about probably 1 in 3 seems to be the research, from 15% up to 33% will across different studies. And then we want to think about compartmentalization. The person with the dissociative subtype might have the out-of-body experiences, but not the voice hearing. They might have the flashbacks, but not the emotional numbing. So these are not necessarily correlated, but rather compartmentalizing experience. To conclude, however, we want to look towards the therapeutic perspective. In trauma, when the sense of self is a sense of self that feels traumatized, we have an alteration in the sense of time. They feel like they're in the past. They have an alteration in the sense of thought. My thoughts, my voices take control. A sense of the body is altered. I'm outside of my body doesn't belong to me. Or the sense of the emotions are altered. I can't feel. I can't get away from what I feel. In recovery, which is what we want to see, we're moving forward, the sense of time is changed. Now I feel like I'm in the present. The sense of the thoughts are changed. I own and am now in control of my thoughts. The body, the sense of the body changes. I'm in my body now, and I know it belongs to me. The sense of the emotion, I can feel and know what I'm feeling. So I thank you so much for listening to this presentation. I look forward to hearing the ideas that you have about it. This is just describing one sort of conceptual framework to differentiate 4 different dimensions of consciousness: time, thought, body, and emotion, in a normal waking conscious form as expressed in PTSD without the dissociative subtype. versus the presentation, the alteration in consciousness, the trauma-related, indeed, altered state of consciousness that might also be present in the dissociative subtype, having to do with alterations in time, thought, body, and emotion. Thanks so much.
So any audience member in Saskatoon, if you would like to ask Dr. Frewen questions, please approach the mic. And participants via live stream can email your questions to my email account, and I'll read them out to Dr. Frewen. Well, maybe in the meantime, Dr. Frewen, we were hearing from Dr. Munson this morning, and she was sharing with us that she was trying to look up some evidence as to how neurofeedback works in PTSD. And so I know from reading your bio that you have special interest in neurofeedback as well. So I wonder if you can perhaps, I know you probably can give another 60-minute talk on that, but whether you can share some of your experience with neurofeedback in helping people with PTSD with us.
Thank you. And thanks, Candice, for raising that question as well. So I think here there is, in fact, a systematic review on EEG neurofeedback as a treatment for PTSD. There was some early studies in the 1990s, and then there are now a few more recent studies. But I would say, in particular, more recent studies have to do with essentially sort of experimental proof of concept to see if indeed persons with PTSD might be able to modulate their brain rhythms through self-regulation. That is neurofeedback. I think I'm assuming most in the audience will have the concept of what neurofeedback is, essentially providing a real-time measure of the brain state to the participant. So, for example, through EEG, but it could also be through some other measurement like functional neuroimaging and like MRI. And then we essentially have a number that describes our brain state in the here and now. There's very little lag in the EEG. Essentially, it's instantaneous, whereas for the MRI, there is a lag of around 6 seconds. But essentially, we get to sort of know what our brain state is through one measure, and then we're suggested to try and change the number. And it might be through some kind of stimulus. It might be a bar graph or a line graph, or it might be some other stimulus that's maybe a circle that's enlarging or shrinking like a balloon or so, deflating or inflating. And we sort of might be given the instruction, okay, try and make the balloon bigger, blow it up, as opposed to deflate it and such. And so we try to learn how to do that. And there's different strategies. One would be to actually give the participant some kind of helpful hints in terms of how they might achieve that. Another approach is actually not to give them any instruction and let it just be an intuitive process. And I think that's actually probably the better way to do it because the specific hints and such might actually work for one group or one individual and not so much for another. So to have this be more of an emergent process and through just the intuition, when I seem to do this, the balloon seems to expand. Okay, I'll try and do more of that then. And it may, however, though, be something that I can't necessarily actually even articulate as to what, in fact, I'm doing to make the balloon expand and make that number go up versus down. I may not be able to put it into words, but at some kind of intuitive, maybe nonverbal level, I'm able to succeed, essentially. So I'm able to make the effect. And so what we're especially focused on right now is this proof of concept level, but we also have Dr. Lanius, being the principal investigator on this particular study, have undertaken a randomized controlled trial. And what this approach that we're really focused on is actually on the posterior midline cortex. So under the PZ electrode, essentially just standing for the parietal lobe and the midline parietal lobe, we would record the EEG from that area of the brain. And in particular, we would record the dominant rhythm, that is the alpha 8 to 12 hertz rhythm, and tell the participant on screen, just basically give them a number for that, and see if they can actually decrease that number. So we're going to try and decrease the alpha. And this is, for those that are familiar with EEG, actually potentially quite counterintuitive because oftentimes we think of the alpha rhythm is actually associated with sort of a relaxation kind of response. And in meditation, typically the alpha goes up. So if we want to sort of try and learn to relax, we would probably want to learn how to increase our alpha. But actually, what's also been shown among meditators is to essentially decrease the slow wave from midline parietal cortex, and we can actually even isolate it to the posterior cingulate cortex, to try and decrease the slow waves there, including the alpha, is associated with an experience of effortless awareness and is a sense that the person can orient towards their experience sort of without sort of trying. There's kind of a sense of being open to new experience. And this has kind of compelled us to try and see if the person with PTSD could affect that change. So a few years back, we published the first fMRI study to show the neural correlates. First, yes, they can affect the change on the EEG, and what are the fMRI neural correlates of doing so. And we can see correlated response in the midline parietal lobe and also in the insula and other areas. And so first, that was just a proof of concept to see if they can do it. And now it's been taken forward to see what might be the treatment outcome. And the treatment outcome is compared to a sham control. So essentially, people are thinking they're doing neurofeedback, but in fact, they're not. And this is over the course of 20 sessions, and it was found that the group that got the true PZ, reducing your alpha neurofeedback, they could indeed do it. They could reduce their alpha session by session. It was tending to be associated with sort of a positive emotional response, and it is mediating symptom reduction and quite decent outcomes, actually, and far statistically and clinically significantly better than the sham group. At the same time, what I would say is we're conceptualizing this kind of an intervention as being a potential augmentation of the psychotherapeutic outcome. We would never suggest that an intervention like EEG neurofeedback should take the place of psychotherapy, but rather potentially it could add to and sort of produce even better outcomes. And that's the hope, but that is essentially pure speculation at this point because that has not been evaluated. So at this point, that could just be a relevant question, I would say, to look at for future research. In this particular study, persons got essentially very minimal psychotherapeutic attention. In both groups, it was a 1-hour session each week, and the majority of that session was the neurofeedback, and then they did, of course, get some psychological attention as well, of course, in those sessions, but that would then, of course, be common across the groups. It was a double-blind study where the therapist delivered both the neurofeedback intervention and the, let's say, psychological, which was minimal, attention during the sessions, but the therapist did not know whether they were delivering the true EEG neurofeedback or the sham, so the placebo control. So what we might say is potentially this could augment psychotherapy outcome. I hope we did learn earlier in the day that we have very good psychotherapies. We're always wanting to, of course, try and improve our outcomes. And we have some good treatments, but perhaps we could even do better. And so one rationale would be definitely not to take away the psychotherapy, but rather perhaps to add to the psychotherapy another intervention. This could be sort of an independent intervention that, for example, you see your psychotherapist and then you also see your neurofeedback therapist. But I don't think that's going to be the best way. Potentially, even the neurofeedback intervention provided right before the psychotherapy could even be something that, if we can affect this kind of openness, this effortless awareness response to the neurofeedback, this might put a person into a greater receptivity for the psychotherapy.
Dr. Frewen, thank you so much for your response. We do have one member of the audience really wanting to ask you a question here in Saskatoon.
Wonderful. Great.
And we have about just a couple minutes.
Yeah, okay. And so I'll try and make my responses less wordy.
I was just curious to hear your thoughts on how your model might translate into work with children and youth, in terms of those who present clinically, both with how we conceptualize dissociative symptoms, and what might help distinguish between those two groups that present with the high PTSD with dissociation, as well as those that present with the high PTSD without dissociation.
Very good, thank you. And so, so one thing just to say is that these dissociative subtype presentations have been shown to be a risk factor, sort of an etiological factor, is the childhood trauma. So if we've got a child who's been traumatized, it is quite possible that they're going to be presenting more so with the dissociation. And so one way to conceptualize the dissociation, actually the child trauma is sort of being more necessary even for the development of the dissociation, is that this normal waking consciousness, the non-dissociative, it seemed to be essentially an achievement of the development of consciousness. That is, in the child is more prone to imagination, to believe things that, for example, they need reassurance that their nightmares are not real, for example. So we have this kind of greater flexibility, essentially, of experience of the child. And so the greater capacity for alterations of experience in the child. As we grow up, as we experience is less new to us, essentially, and so it becomes more fixed and firm. And so we know more readily that our nightmares, of course, are not real. So now in the adult, we might have had if we have the dissociative subtype, it's more likely that this came about as a result of the childhood trauma and not as having sort of more fluid brain state that openness to the alteration. So one thing I would say to this then is just to say in the child that these dissociative presentations, I would indeed sort of try to assess for it. And I think, though, the question is, might it be expressed in a very different way? I would say, for one, a lot of these symptoms that we're presenting here are sort of at a high-level language. The child's not going to be able to necessarily articulate whether they experience, voices, or whether they feel like they're outside their body. It's a very high-level language. And so we're going to have to provide some more appropriate ways to assess this. But I think we can certainly identify whether they're experiencing flashbacks, the sort of form or quality of their thought, or whether they sort of appear to feel like they can sort of move freely in their bodies and sort of feel like they belong to their bodies through their overt behavior, and what kind of emotions are they experiencing. Is it a very high arousal, or is it a low arousal? They appear or more detached or numb, non-responsive. And I would say that those are more the markers of the dissociative presentation, be it in the adult or a child.
Thank you so much, Dr. Frewen, and we really appreciate that you joined us today, even though you could not be here. And thank you so much.